Okay, I think we can go ahead and get started. Um, Great. Well, welcome everyone. Today we are fortunate to be joined by one of our own, Dr. Cara Pellegrini. Um, so by way of introduction, Dr. Pellegrini is the Director of Cardiac Electrophysiology at the SFVA. She has had a long-standing interest in atrial fibrillation, and today we'll be providing us an update in light of the recent new atrial fibrillation guidelines. Dr. Pellegrini grew up on the East Coast. She graduated from Princeton, where she was a co-captain of the women's water polo team. After med school and residency at the University of Pennsylvania, she and her husband moved to San Francisco for cardiology fellowship and for his ID fellowship. Dr. Pellegrini joined SFVA following EP fellowship, and she says despite holding only one real job in her career, she has had many accomplishments. Some highlights including her role as Associate Program Director for the Cardiology Fellowship, a 3-year stint as Acting Chief of Cardiology at the VA, a current collaboration as a member of the VA Cooperative Studies Grant, and work with the Heart Rhythm Society and ACC on guideline committees, the Education Committee, and Scientific Session Planning Committees. So with that, Dr. Pellegrini, I'll let you take that away.
Awesome. Thanks, James. Can you hear me okay? Okay, great. It is such a pleasure to be with all of you today. Thank you for taking time out of your busy schedule to talk about something that I really like anyway. And thank you, James, for the invitation. Let's see here. These are my disclosures, and I hope that none of them will introduce bias into today's talk. I thought just for fun, we'd get started with a case. And feel free to put your thoughts in the chat just for my amusement. So this is a 68-year-old woman who presents to you for care. At the end of the visit, you've done a lot of work together. She offhandedly mentions that she's been getting some alerts about a possible AF episodes from the smartwatch that her kids just gave her for Christmas. And you, A, eagerly asked to see the tracing, B, start the discussions of the pros and cons of a Watchman implant, C, put in the EP referral for AF ablation, D, forbid her from drinking any more coffee, or E, sigh quietly to yourself. So I think there's one right answer here, and this talk will be a success the more that I'm able to convince and engage and excite you all about atrial fibrillation as a disease process. Indeed, this tracing does show that this episode was real AFib, but we certainly don't take that for granted with our wearables definitively. And so today we're going to talk about a few things. We're going to talk about atrial fibrillation as a progressive disease as a concept, a little bit about thinking about subclinical atrial fibrillation. We're going to talk about atrial fibrillation management, specifically with regard to stroke prevention and ablation, touching on anticoagulation, left atrial appendage occlusion options, equity, and some new energy sources for ablation. And I will do my best to ground all this in guidelines, the recent guidelines that just came out in the last couple months, and try and keep this talk very practical. To that end, if things aren't clear, please feel free. I won't be manning the chat during the talk, but hope to have some time for questions and discussion. And certainly if things are going off the rails, stop me sooner than the end. So I don't think for any of us, it's a surprise that if a patient gets a stent, that they could still have a heart attack in the future. That one little focus does not necessarily, treating that does not necessarily do anything to alter the process of the disease that's ongoing. Similarly, we're all very familiar with the idea of heart failure as something that gets worse over time. But I think it's been a little bit of a more recent development that people have really begun to understand that atrial fibrillation too is a progressive disease process. And I think that that's a really important concept to think about the risk factors for AFib and the ability to take action early, maybe even before patients are symptomatic, to alter and impact this process. And so I think that this concept, it lends itself well to this idea of taking action. So as we think about mechanisms of atrial fibrillation, we know that that electrical remodeling, which both contributes to and results from atrial fibrillation, includes calcium mishandling and action potential shortening. And delayed after depolarizations can give rise to PACs, which act as triggers for atrial fibrillation. At the same time, atrial hypertrophy and atrial cardiomyopathy can give rise to heterogeneous and slowed conduction through atrial tissue, which helps develop the substrate that then allows that atrial fibrillation to take hold and persist. Some of the mediators, such as oxidative stress, inflammation, and autonomic dysfunction, help explain and connect some risk factors, such as hypertension, coronary artery disease, obesity, alcohol exposure, and sleep apnea, to the outcome of atrial fibrillation. And I think this is important as we think about and understand, why some of these things can lead to this disease. So the new guidelines for the first time really make a point to show that thinking about treatment of risk factors really should be the foundation of how we think about AF management, not just an afterthought, and really as a foundation should be something that we think about for all our patients and think about broadly. You'll note that many of these risk factors are things we're, as cardiologists, very commonly used to dealing with. Things like tobacco, alcohol, hypertension, diabetes. These are things that we already have in mind. Sleep is one that maybe is a little more unique in the atrial fibrillation space. I think exercise is kind of interesting as it has a bit more of a complex relationship in a J-shaped curve. Happily, I think for most of us at this talk, we can exercise as much as we would have time to quite safely. But I'd like to explore alcohol a little more deeply, as I think that too has a little bit more complexity to its relationship, and a lot of the foundational work has been homegrown here by Greg Marcus and colleagues at UCSF. But first, we're going to go to Australia, where I think a lot of the work for risk factor modification in atrial fibrillation have really started. And so this study was one of the first to look prospectively in a randomized way to think about can abstinence as a strategy impact secondary prevention of atrial fibrillation. And so they took 140 people who already had a diagnosis of atrial fibrillation and had some regular alcohol consumption, but excluded those who were really heavy or had alcohol problems, and randomized them to an abstinence group and a control group. Both groups did decrease their alcohol intake, and neither to zero, but the abstinence group went from an average of about 17 drinks per week to about 2 drinks per week, an 88% reduction, whereas the control group started around the same place and reduced by about 20%. And with that, over a 6-month follow-up, excluding a 2-week blanking period to kind of get things going, you can see that the abstinence group had a recurrence of atrial fibrillation episode of about 50%, which is significantly lower by about half than the 75% recurrence in the control group. And this was accompanied by a lower percentage of time in atrial fibrillation in terms of just duration over that time period, as well as a longer time until the first episode of recurrent AFib. I think a further nail in the coffin of our confidence of 1 drink a day, keeping the doctor away, came from Greg and his collaborators. And this was, I think, a really provocative and elegantly designed study. They took about 100 patients, again, who already had a diagnosis of atrial fibrillation, and who had some alcohol intake, mostly in the mild to moderate range, again, excluding patients who had alcohol use disorder, and followed them very closely with continuous ECG monitors, a transdermal alcohol sensor, periodic blood alcohol assessments, and patients or participants also kept a diary of their alcohol intake. And I believe there was pretty good correlation in the different methods that were used for monitoring alcohol intake. And when they mapped AF episodes to use of alcohol, you can see that there was a peak in odds ratio that about 2 to 4 hours after an alcoholic ingestion was the peak time of likely AF episode. And that then odds decayed over time until about 10 to 15 hours later when got back to a baseline risk. Interestingly, there was a linear relationship with dose, or an increasing relationship close to linear with dose, such that the higher alcohol intake, the more likely to have an AF episode. And you can see even just with one drink, your odds of an AF episode in the next 4 hours was doubled. So no clear threshold effect that was noted in this study. Sorry. A slightly different story came out of this UK Biobank study. Our own Chris Wong, for those of you that remember, was one of our EP fellows and went back to Australia. So this is another collaboration from abroad. But they had thousands of participants here in this UK Biobank study. In this case, we're looking at incident AFib. So they took patients or people who had not had a diagnosis of AFib already and had them fill out a questionnaire, I believe just at baseline in terms of their alcohol intake, and then looked at incidence of AFib and matched that on the basis of self-reported alcohol use. And you can see with this methodology, looking at incident AFib, it looked more like a J-shaped curve where it seemed that there was maybe some protective effect of very low use and then a harmful effect as your use went over about 7 to 10 drinks in a week. Now, a couple of things to note about this. One is that the UK standard drink a week is significantly less, 8 grams of alcohol compared to the American standard drink a week, which is more like 14 grams. So I think our understanding of exactly what is a low dose is a little bit different. And again, I think there's some potential for recall bias and change in pattern of alcohol use if you're only getting a baseline and self-reported information. So those are some of the reasons perhaps to be seeing a difference here. For what it's worth, I thought it was provocative that they saw different risk patterns for different alcohol uses, such that perhaps wines were more protective, whereas beer and cider didn't seem to have any of that J-shaped curve. So taking that data together, the new guidelines recommend either abstinence or a very small amount of, that is to say, 3 or fewer drinks in a week. They came down with some very specific recommendations on other things as well. Again, I think many of these are familiar to all of us here with respect to controlling, I love that my lights go out here periodically, controlling sugars, controlling blood pressure, weight loss up to 10% if overweight or obese. I want to highlight that, and I'm sorry, we don't have time to go into the details, but even moderate to vigorous exercise up to 210 minutes per week, and this has included things such as intense interval training, still seem to be perfectly safe. So only when you're getting into kind of the marathon running and extreme cycling, generally does exercise enter into that extreme space for the most part. I also just want to highlight, and again, not getting into the detail, but caffeine has been somewhat debunked, at least as a common trigger for most people. So we've talked a little bit about treating risk factors, and we'll talk more about our symptomatic treatment for our active AFib patients. But I want to spend a moment now and think about, might there be a role for screening for these pre-AF patients? So this stage 2 is meant to encompass people who have not yet had AFib observed clinically, but who have started having some changes in terms of atrial remodeling, either electrically or structurally. And so these people who are kind of more at high risk, might we be able to kind of nip this in the bud early on? And might that be helpful? And so we're moving into subclinical AFib. So 2 studies have come out in the last year, right on the heels of each other, that were looking at a very specific population, those with cardiac implantable devices, and looking to see if randomizing patients who have this asymptomatic occult detected AFib by a cardiac device, if randomizing them to oral anticoagulation could be beneficial. The first study to come out, the NOAA AF-NET 6 trial, had a composite endpoint that included cumulative incidence of stroke, systemic embolism, or cardiovascular mortality, and randomized patients to edoxaban versus placebo. And as you can see on this graph on the left, there was no statistically significant difference between those 2 arms with regard to this composite endpoint. As you see on the right, however, there was a significant excess in major bleeding that was driving this cumulative incidence of major bleeding or mortality in the edoxaban arm that led to this trial being terminated early. Some would argue perhaps before there might have been the opportunity for benefit, a small benefit to have been seen. And so this was followed quickly on the heels by Artesia. Again, looking very similar patient population, those with an elevated CHA2DS2-VASc of, I think the average was about 3 or 4, patients who had a cardiac device and who were having atrial high rate episodes, which pretty well maps to atrial fibrillation lasting 6 minutes or more. In this trial, it was a little bit bigger, and they had a composite endpoint of stroke or systemic embolism, so did not have mortality as part of their composite endpoint, and had a different DOAC, in this case apixaban, with a different comparator, importantly aspirin, not placebo. And you can see that in contrast to our last trial, that this one did meet their primary composite outcome, with a near 40% reduction in stroke or systemic embolism with the use of apixaban as compared to aspirin. Similarly, there was a near 2-fold increase in bleeding in the apixaban group as compared to the aspirin group. So there were more excess bleeding events than decreased stroke events, and we'll come back to that in a moment. Or talk about it even right now. So comparing these trials, how do we synthesize this information? So I think the first take-home point is that the risk of, or the incidence of stroke, of ischemic stroke in both of these trials was pretty low, was around less than, was 1% or less for all arms in both of these trials. And as compared to patients with clinical atrial fibrillation, that is with a similar CHA2DS2-VASc score, it's worth noting that this is significantly lower. And that's no surprise. We know that patients who have clinical atrial fibrillation at a given CHA2DS2-VASc score versus just people who have that CHA2DS2-VASc score and have subclinical AF, that the clinical AF is at higher risk. The next thing to point out is that, as I said, bleeding events were more common in both of the DOAC arms. The placebo arm, even in the NOAA group, about half of those patients were taking aspirin, as compared to a much larger percentage in the aspirin group of Artesia. But I think that that explains in part the similar bleeding risk in our comparator groups here. So I think that the question here is it worth it? I mean, so we understand that we're increasing bleeding by numerically more than we're decreasing stroke. And I think many in the EP community, when these studies were put forward, said, maybe not yet. I'm not convinced. What the researchers put forward that I think is worth at least thinking about is that most of the bleeding events, the excess bleeding events that did happen, did not require emergent care, did not result in unavoidable death. And on the flip side, most of the strokes that were prevented were of a higher severity, with a Rankin score 3 to 6, specific stroke being threefold less likely in the apixaban versus aspirin group. So, maybe not an apples to orange comparison of 1-to-1 ratio makes sense here. And this is where I think, the art of medicine comes into play. If there might be a certain patient in front of you that, that you might think about this. How do the guidelines take this data? Well, I should say that the guidelines actually did their data analysis before these trials were out, but I don't think anything would change very much. You can see that if an episode, a high rate episode, is less than 5 minutes at the longest, the recommendation is no benefit. Do not anticoagulate these patients just for this reason. However, if there's an episode that's more than 24 hours, even if it's asymptomatic, and the patient has a CHAS-VAS score of 2 or more, then oral anticoagulation really might make sense for these patients, and truly should be considered at a 2A. And then you have this intermediate zone, and this is where I think more data would be helpful, between 5 minutes and 24 hours, where, again, we're left thinking about maybe reasonable. Taking this idea just one step further, what about all the patients that don't have cardiac devices, who are asymptomatic? Might there be a benefit to doing more broad-scale screening of these patients? Well, the first question is, does screening uncover the disease that we're interested in? And that's, I think, a resounding yes. The more that we monitor patients, so these studies in blue had more than just a single touch, and you can see that there was statistically more AFib uncovered. And if you monitor patients for even longer in a continuous way, as shown in red, then you're going to have an even greater likelihood of finding AFib. So I don't think that we are really doubting our ability to uncover this asymptomatic AFib. I think the question is, does it impact outcomes? And so far, there's been really just this one trial, Stroke Stop, that's really been powered to look at clinical outcomes of screening. So this was a study in Sweden where they took patients, people who lived in 2 counties who were 75 or 76, and randomized them to an invitation to screen versus no invitation to standard care. Of those who got the invitation to screen, about 50% took them up on it. So just half of that half. And then looking at their composite outcome of stroke, systemic embolism, major bleeding, and death, and looking in an intention to treat way. So this is all invitees, not just the ones who actually screened. They eked out a slightly statistically significant positive result. Nothing you're going to write mom and dad about, but something perhaps suggestive. And a trend towards significance for ischemic stroke that didn't quite meet significance. Several of us at the VA think that this is still an open question worth exploring further, and have put together a trial that recently got a fundable score, and so we're pretty excited and expect this will likely go forward. So this is a collaborative studies project 2037 that I just want to introduce to you, that I'm very excited about. We'll be looking to screen about 24,000 vets across the country, and about 24,000 vets total. About half will be in the screening arm and half in the usual care. And then the thought will be to provide guideline-based recommendations that will go beyond just anticoagulation, by the way, but include some of the other risk factor modification things that we talked about, give that guidance back to local providers, and then look at outcomes both in terms of safety and efficacy as outlined here. And I hope to have an invitation back in a few years to share this information. And we really feel that, that this folds into future research needs as outlined by these recent guidelines. So I'd like to pivot into thinking about, okay, so what about the patients that are diagnosed? How do we manage them? What's state of the art now? And a little bit about, where are we going with this in the future? So first, thinking about anticoagulation and how we manage stroke rate. You've heard me reference CHADS-VASc, which is the main scoring system and main way that I think many of us think about AF and stroke risk. And it certainly is a great tool for risk stratifying within a given cohort. But I think what I didn't fully appreciate, and perhaps some others here, is just how variable, if you look across cohorts, the rate of stroke is. And therefore, for any given CHADS-VASc score, it becomes hard to pin that down to a specific stroke rate per year. We know that there seems to be a sweet spot around 1 to 2% stroke rate per year for the risk of anticoagulation being outweighed by the benefit. And so, there it was a call in the latest guidelines to think about, how we might do even better. There are other scoring systems out there, in addition to CHADS-VASc, such as Atrial and Garfield, that I put up here for your perusal. You'll note how user-friendly the Garfield system is here. I'm not sure that either of these will catch on in clinical use, but where I think at least at immediate help is if you have kind of a borderline patient in front of you, it might be worth looking at some of these additional risk factors, such as older age, renal disease, current smoking, dementia. That might be a space where, if some of these are present, but you were otherwise on the fence, kind of, might push us a little further. Another thing that enters into the most recent guidelines is this concept of AF burden. And I remember early on, kind of it makes intuitive sense, right? That the patient with more AF would be more at risk of stroke. And that kind of gets hammered out of you like, no, it's like you have AFib and you just have this risk and it kind of doesn't matter. And now it's like a little bit of a U-turn, at least for my thinking of this in a more complex, nuanced way. This data comes from our local Kaiser group. And they looked at tertiles of AF burden among a large cohort and found that tertile 3, those that had an AF burden of greater than 11.4% as compared to the other 2 tertiles, had a 3-fold increased risk of stroke off anticoagulation as compared to the others. And so this data has been rolled in a piece to the latest thoughts about anticoagulation. So as promised, if you have a greater than or equal to 2% stroke risk per year, oral anticoagulation is recommended. And this equates to roughly in North America, a CHADS-VASc of about 2 for men, 3 for women, though again, taking that with a bit of a grain of salt as all 1-point CHADS-VASc elements are not equivalent. And if you have a stroke risk of 1 to 2% per year, a CHADS-VASc of about 1 in a man or 2 in a woman, that's where we're asked to potentially consider other factors, which can include things like burden. And again, giving us some space to have a little more of a nuanced conversation with the patient. This right side of the slide, I think, should be pretty familiar with everyone, but just briefly, DOACs are preferred for all but those who have moderate to severe mitral stenosis or a mechanical valve. No benefit to aspirin in patients who don't have AF risk factors, so CHADS-VASc of 0 and AFib. We don't recommend aspirin for that reason. And aspirin plus or minus the addition of clopidogrel is harmful if that's being used in place of more appropriate therapy, such as oral anticoagulation. Where the guidelines still don't give us any information, however, is what should be our default agent. I think here at the VA, we use a lot of apixaban, and I think that there is good reason to suggest that that agent may be the best. I tell my patients you're getting something on sale here because I think that apixaban probably does have a lower bleeding risk as compared to rivaroxaban, the second most common used oral anticoagulant in this country. They've not been compared head-to-head in a prospective randomized way, but we can extrapolate somewhat from their comparisons to warfarin in Rocket and Aristotle. Now, these were different patient populations for sure. The Rocket patients were sicker, older, et cetera. But using warfarin as a standard bearer comparison, we can see that there seems to be a signal of a lower bleeding risk of apixaban as compared to rivaroxaban, comparing each to warfarin. And this is recapitulated in observational studies. And I know, I know this is really small, but the homogeneousness of this, I think, is meaningful. Again, with apixaban seeming to have a lower bleeding rate than rivaroxaban. Similarly, if we look at efficacy, there again seems to be a signal that apixaban may be superior to rivaroxaban. Again, going back to warfarin as our comparator. However, again, we really think that these drugs should be compared head-to-head. That hasn't yet happened, and that's the other half of what we've proposed to do here in CSP 2037. Randomizing about 10,000 veterans to apixaban versus rivaroxaban, and looking at both efficacy and safety endpoints over a 3+ follow-up year period. And again, I hope to have more data to share with you in the future. Now, there has never been a better time to not be someone who wants to be on oral anticoagulation and have atrial fibrillation. There are a plethora of options, 2 of which have FDA approval, the Amplatzer Amulet and the Watchman Flex. And the Lariat is also in clinical use through kind of a backdoor portal. I apologize, the slide looks just a little bit blurry, but this is 5-year patient patient-level meta-analysis data from PROTECT and PREVAIL that I think is provocative for well, one main reason. I don't think super surprising that hemorrhagic stroke is going to be lower in the group that gets Watchman, and ischemic stroke, though not statistically so, trended to be a little higher in that group. What I do think is interesting is that mortality was statistically significantly lower in the Watchman group, those randomized to Watchman as compared to warfarin, albeit not our most standard comparison these days, but provocative. Indeed, the Watchman implant has gotten a lot safer. The most current device registry data would suggest a complication rate of around 0.5%. And I think taking all that data together is probably where we got a broadening and a higher level of recommendation in the guidelines for consideration of left atrial appendage occlusion, such that for patients with atrial fibrillation and a CHA2DS2-VASc of 2 or more and a contraindication to long-term oral anticoagulation use, we now have a 2A as opposed to a 2B indication for consideration of left atrial appendage occlusion. And we have a new 2B indication for that same group of patients with AFib and CHA2DS2-VASc of 2 or more, who now just are at considered higher risk, so haven't necessarily had a contraindication, but just were more concerned about these patients. Where I think we really don't have enough data is in how we manage the post Watchman antithrombotic period. There are 2 FDA-approved strategies, either just 6 months of DAPT going to aspirin, or oral anticoagulation and aspirin, and then aspirin Plavix to complete the 6 months after this 45-day period and TE showing no clot, and then graduating to destination therapy of aspirin. Jim Freeman and colleagues have shown that that's not what's done in the real world, that there's a whole plethora of things that are actually being done. I suspect that if this was slightly newer data, there'd be smaller chunks with warfarin. And Jim has also published that some data suggesting, gosh, do we even know for sure what is the best strategy? Those who were not given aspirin on top of their oral anticoagulant seem to have lower bleeding risk and therefore lower adverse event rates overall. I suspect that by the time we figure out exactly how best to handle Watchman, we'll have a whole bunch of new techniques that, maybe we won't even be doing that. This one that Ram and I was just sharing with me the other day, I think it's kind of provocative. It's sort of a inversion of the left atrial appendage internally and sort of an internal lariat, if you will. And the thought is like something like this, you're not exposing any hardware to the blood pool and or having any little residual left atrial appendage where a clot could still form. This is very early stage, this particular applicator, device, not yet in trials to my knowledge, but kind of thought-provoking and exciting. We at the San Francisco VA have a robust Watchman program right now, and I'm really lucky to have a great team. Rick and I trade off on doing the implant versus the transeptal. Neil's been a really lovely partner for us for imaging. We've got a great rep from Boston Scientific who brings a lot of knowledge to the table, and we've are doing enough of these that we can really get the fellows involved hands-on. And I think it's a nice addition to be able to offer this to our patients. Moving on to ablation, I can't believe Cabana trial is now almost 5 years old. The Cabana trial, for those who don't remember, was one of the largest prospective trials to randomize patients to ablation versus drug therapy and look to try and see if there might be a difference in hard outcomes, specifically mortality, disabling stroke, serious bleeding event, or cardiac arrest. It missed that composite endpoint, but did show us again confirmation of earlier data that ablation just clearly very firmly outcompetes drug therapy with respect to AF freedom. Moreover, again, confirmed that quality of life ablation is superior by lots of different measures as compared to drug therapy. And I think slightly more interesting, this was a larger trial, and we're able to say that even among the oldest group included, those 75 and older, ablation, again, was superior with respect to AF burden, and that the safety of the procedure was similar in all these age groups. The mortality benefit of ablation seemed to be inversely related to age. Just makes sense, right? As you have more competing mortality, you're going to dilute any potential benefit that ablation may have. But, potentially leaving open the question if, at this younger age group, might there still be a mortality benefit that we weren't able to prove? There certainly is good data for the group of patients who have HFrEF, and to a lesser extent HFpEF, that ablation is superior to medical therapy for hard outcomes like heart failure, hospitalization, and mortality, both as a composite and individual outcomes. I'm showing the intention to treat analysis from Castle AF here, the composite outcome, but their individuals were not too different, with a 40% reduction in hazard with ablation versus medical therapy, despite all these patients having devices, and we know they still have some AF burden. The more recent trial, Early AF, furthered our knowledge in showing that that ablation decreased progression to persistent AFib as compared to medications. So in this study, they had about 300 patients that had paroxysmal AFib. They were relatively young and healthy, randomized them to antiarrhythmic drugs versus ablation, and found over a follow-up of about 3 years that about 2% in the ablation group went on to have an episode of persistent AFib as compared to about 7.5% in the antiarrhythmic group. Quality of life was more improved in the ablation arm, as was the serious adverse event group. I'm sorry, serious adverse event rate was also actually lower in the ablation arm, perhaps because they were really cranking on the antiarrhythmics in this as they were going for no AFib, not just reduction. But I think provocative and I think weighs into the committee's mind in giving AF ablation now a class 1 indication with level of evidence A as first-line therapy for selected patients with symptomatic atrial fibrillation. And note, I think we really should emphasize this is selected patients, not every single one who gets referred, but something to think about. And then perhaps even more thought-provoking, a 2B indication for patients with minimal to no symptoms, catheter ablation may be considered, may be useful for reducing progression of AFib and its associated complications. And again, I think we know that about a third of AF episodes will go on, patients with AF episodes will go on to have persistent AFib. And there is this window where we know early on that ablation is much more successful, and still this open question about, may ablation be beneficial for other outcomes, stroke, perhaps mortality in some subset, and should we be thinking about being more aggressive even in some patients with minimal to no symptoms? This is, results like that are what make me a little more upset seeing these results. So a few words about equity. Even as our AF ablation numbers have really been growing, and I think this chart stops at 2019, but I expect that this slope of this line would have even increased in the last few years. There doesn't seem to be any closing of the gap between those in the Latinx or Latinx or Black group at the bottom lines here as compared to the white and Asian group on top in terms of receipt of ablation. And going back to Cabana data, this sub-study, elegantly done by Kevin Thomas and colleagues, suggests that ablation is actually particularly beneficial among racial and ethnic minorities, making this pattern of access even more concerning. So here, again, they took patients randomized to drug versus ablation and just split them into minority as a congealed mass, excluding Asians, but others altogether, versus non-minority. And you can see the minority group is in the solid blue and red line and the non-minority in the dashed line. And while the non-minority dashed lines are relatively superimposed, the minority, you can see, had much worse outcomes with drugs than with ablation, suggesting that perhaps there's a particular benefit of ablation or particular harm of some of these antiarrhythmics that we're giving these patients. And again, I should have mentioned that this is not AF burden, but we're back to this primary, very hard outcome composite endpoint of cardiac arrest, all-cause mortality, a high serious bleeding or disabling stroke. So I thought that was pretty provocative. And when we look at mortality alone, we can see a recapitulation of the same thing. Again, this is just looking in the minority group, but seeing a significantly lower risk in the ablation group as compared to the drug group. Again, it's a sub-study. We take it with a grain of salt. Another thing I should point out is, again, we're lumping all minority groups here, or multiple anyway, minority groups here together. There's not necessarily biologic plausibility that everyone would be the same, but this shortcoming notwithstanding, this is the biggest piece of data that we have looking at outcomes of AF ablation in minority population specifically. Finally, I'd like to end with a few thoughts about some new things within how we're doing ablation for patients. So as probably most of you know, we mostly have been using thermal energy to do our AF ablations. That can either be hot with radiofrequency ablation or cold with cryoablation. And there's been some limitations in terms of making durable lesions that last over time, in terms of safety, with the potential for collateral injuries to the esophagus, to the phrenic nerve. And that has left us, still exploring, might there be better things out there? And so post-field ablation is something that's been garnering a lot of attention recently. And the idea here is that there's a train of these microsecond, high amplitude electrical pulses that damages the cell membrane, leading to cell apoptosis, but is very specific. And so the dose for cardiomyocytes is significantly lower than for other tissue. And you don't have to have the same direct pressure to the tissue to be able to have a really thorough result. And this slide with this gross specimen is meant to demonstrate that you have this really clear demarcation of where the tissue was impacted and nearby tissue being completely unaffected. And you can see that even in the areas of, deep within these trabeculae where there wasn't direct contact, we're still seeing a really good full thickness lesion. Moreover, going to safety here, we're looking at pig esophagus, and in this right picture, esophagus and aorta. And with radiofrequency ablation directly applied, no surprise, we can create an ulceration, and that's a big concern for us. Even with obviously not directly applying to the esophagus, but being nearby, with the left atrium being so posteriorly located. Conversely, with PFA, even with direct application in the esophagus or aorta, no harm at a cardiac type dose. There has been some human data. This is non-randomized consecutive patient data of a cohort looking at cryo versus PFA and showing similar freedom from atrial fibrillation, so similar efficacy. However, the PFA procedure was significantly faster, which is a meaningful thing in terms of potentially reducing complications. And it did seem to be safer with regard to number of phrenic nerve injuries in this study. We still have several questions that we don't know. There's a bunch of different companies. They have different catheters. There's different ways that you can deliver this energy. We're not sure exactly, what's most optimal. So I think there's a lot of study yet ahead, but this is promising and exciting. And I do predict, I know UCSF was part of one of these trials, and I do predict that you'll be seeing more of patients that you're referring for AF ablation being treated with this energy within the next year or two. So as I look ahead and hope about our future for AF management, I would really like to see more early recognition of this entity, maybe even in the preclinical stage, as we talked about, which then couples well with this idea about having early intervention, thinking about risk factor management, hopefully in some sort of multidisciplinary AF clinic where, really the time can be spent to do this hard work. I'd like to see more nuanced consideration of stroke risk reduction and more options for patients in terms of how we might achieve that. I think thinking about ablation early, getting those referrals to us for AF ablation for appropriate patients early, thinking about new technologies to make these procedures safer, faster, hopefully more efficacious, maybe even. I would really love to see more equity in both our treatment and our research, and then coming back around to thinking about targeted prevention. And this is one of the references for the latest guidelines on which a lot of this talk spoke about. And with that, I'll end with some time for questions. Thanks for your attention.
Great. Thank you, Dr. Pellegrini. I think we've had a little activity on the chats, and since Dr. Goldschlager, I see that you have shown your video. Maybe we can start off with you.
Yeah, hi, Cara. Good to hear you and see you. I have one issue of definition because I'm unimpressed with the uniformity of paroxysmal persistent, long persistent, and chronic or permanent, which I don't even know is useful anymore. What is there a uniformity of definition in your opinion? And how useful is it, which I think it is? how we think about, is this really paroxysmal, persistent, long persistent? What's the difference? Number one. Number two, if I could, James, don't get mad. I wanted to know if there's any ECG, P-wave morphology duration that could be used as a predictor. What are your thoughts about predictors of ECG abnormalities, specifically left atrium, predictors of AF? And one more question. There's been a brouhaha about atrial fib and dementia. Do you have thoughts about that?
I forgot them. Just kidding. Okay, so Nora, I thank you so much. You've been such a leader in this field, and again, no surprise, have some thought-provoking questions, and I'll try and hit them all. So briefly, with respect to definitions, thank you for keeping me honest. So persistent atrial fibrillation has been defined as lasting 7 or more days of continuous atrial fibrillation, with longstanding persistent lasting more than 12 months. Is the working definition, at least for the purpose of these guidelines. So less than that would be paroxysmal. And then permanent is really just, that we're accepting that this is atrial fibrillation, and we're not gonna, try and make any rhythm control changes. If you look here in stage 3 with this arrow kind of going both ways, the thought is that it is possible for people to kind of shift. It's not a one-way street. So you can be in, persistent or even long-standing persistent AFib, and maybe you have an ablation or you do some really significant risk factor modification. Look at data out of Australia, again, the reverse trial, they were able through weight loss to take some of these persistents and long-standing persistents without even ablating them and bring them back to paroxysmal or even no AFib, which is really provocative. So these things are not meant to be necessarily unidirectional, and but those are the definitions. The second question that you gave, let's see, you mentioned about dementia, and then you mentioned about, AI, I think, right? You were talking about prediction models. I assume you're talking about things like AI, and I know Joff has been doing some amazing work in this space. Neil's done a little bit as well, and I apologize. I thought about adding a slide on that and just had so much here, but yeah, I think we're getting better and better about being able to predict, looking at an ECG and predict a whole bunch of clinical outcomes, AFib among them. I gave another talk about arrhythmogenic mitral valve prolapse, and Joff and colleagues had done, Francesca and others had done a really nice paper about using AI to predict who among all these patients with mitral valve prolapse might have arrhythmogenic events, which I thought was perhaps even more useful. But yeah, I think we're still refining that, but I think there's a space for that. And again, that's not part of what we're going to be looking at in CSP 2037 screening trial, but I think there's lots of different things one could put in thinking about how we identify these highest risk people, and more to come on that for sure. And then as far as dementia and AFib, yeah, there definitely seems to be some signal there. And again, might an AF ablation, be meaningful in that way? At the same time, we know that, we see gray matter or white matter lesions after AF ablation of unknown significance that then fade. Beyond the scope of the talk today, but yes, there definitely is something there, and I think Don, who I know is on this talk, and I had talked before and have been a little sidelined about looking into that, and whether something like cardiac rehab or exercise could have an impact on that, and I think there more research needs to be done in that space. Thanks for the good questions.
Thank you for the answers.
Sarah Goodman from the VA had a question regarding how to counsel patients with permanent AFib on alcohol use. I'm not sure if you can see the question.
Yeah, I can. So, I mean, it depends what your goals are, right? So if this is someone who you're not aiming for rhythm control strategy, sorry, that scared me. If it's someone who you're not aiming for rhythm control strategy, then, maybe you don't need to be as strict. Maybe you don't need to be as strict with respect to, trying to get them down to 3 standard drinks per week or less. Even for those, though, that you're doing a rate control strategy, alcohol in high amounts can certainly, cause tachycardia, can cause other cardiomyopathies and other problems. So I think there are certainly other motivations that you might have beyond just rhythm control with respect to thinking about alcohol use. But for the patients that I'm not aiming for a rhythm control strategy, I'm not as compelled as I am for my rhythm control patients, particularly those in whom we've seen a personal pattern of alcohol being a trigger. But really, with Greg's data, I feel that it's compelling, and I tell my patients, look, even one drink is enough to potentially precipitate an episode. That said, you have to live your life and make value judgments, and we'll do our best to support you, whatever you decide.
Perfect. All right. Well, with that, I want to acknowledge that we're at time. Thank you, Dr. Pellegrini, for this great talk and thoughtful answers to these questions. And we'll see everyone next week, where we have just to advertise our Samson lecture, which will be in person, both on Tuesday for medicine grand rounds at the VA and San Francisco General, and on Wednesday for cardiology grand rounds with Dr. Lloyd Jones. So see everyone next week.
Thanks.